Osteoarthritis and rheumatoid arthritis. Tina Harrison Thornhill, 42, 864, Chapter 42, the third. A. Definition and cause. A. Osteoarthritis is a common chronic condition of articular cartilage degeneration. Secondary changes can occur in the bone, leading to pain, decreased functioning, and even disability. OA affects nearly 21 million middle-aged and elderly Americans. It is the most common form of arthritis. Although not always symptomatic, most people older than the age of 55 years have radiological evidence of the disease. Until age 55 years, OA affects men more frequently than women. But after age 55, women are more likely to have the disease. B. Rheumatoid arthritis. RA is a chronic, systemic autoimmune disease that involves inflammation in the membrane lining of the joints and often affects internal organs. Most patients exhibit a chronic fluctuating course of disease that can result in progressive joint destruction, deformity, and disability. RA affects between 1 and 2 million Americans. It occurs 3 times more often in women and peaks at age 35 to 50 years. 2. Normal joint anatomy and physiology. E. The synovial joint consists of 2 bone ends covered by articular cartilage. The roles of articular cartilage include 1. Enabling frictionless movement of the joint. 2. Distributing the load across the joint, shock absorber, to prevent damage. 3. Promoting stability during use. B. Cartilage is a vascular and a neural. It is metabolically active and undergoes continual internal remodeling. It is composed primarily of water, but is also made from chondrocytes and extracellular matrix. C. Chondrocytes control the synthesis and degradation of the matrix. They produce proteoglycans and collagen in the extracellular matrix to maintain the integrity of the matrix in healthy cartilage. D. The joint capsule is a fibrous outer layer that encapsulates the joint. The joint capsule is lined by synovium, a membrane that produces a viscous fluid that lubricates the joint. E. The synovial fluid is composed, in part, of hyaluronic acid. Glucosamine is a component of hyaluronic acid. The role of hyaluronic acid is to maintain functional and structural characteristics of the extracellular matrix. Bursae are small sacs that are lined with synovial membrane and filled with fluid to provide cushioning and lubrication for the movement of the joint. Third, osteoarthritis. A. Pathophysiology. Many age-related changes contribute to the development of OA. 1. The strength of tendons, ligaments, and muscles declines with advancing age and may contribute to the development of the disease. 2. The number of chondrocytes declines owing to apoptosis, cell death, decreased proliferation, or both. Osteoarthritis and rheumatoid arthritis. Tina Harrison Thornhill. 2. 864, Chapter 42, the third. A. 3. The synthesis of normal proteoglycans is reduced. 4. Chondrocytes lose the ability to promote healing and cartilage remodeling, resulting in cartilage matrix degradation. Proteoglycans are depleted. 5. Matrix metalloproteinases, MPs, and pro-inflammatory cytokines promote cartilage degradation. 6. Interleukin-1 O-1 has several roles in the development of OAA. Induction of chondrocytes and synovial cells to synthesize MMPs. B. Inhibits the synthesis of type II collagen and proteoglycans, preventing collagen from repairing itself. C. enhances nitric oxide production, and induces chondrocyte apoptosis. 7. Pain occurs as a result of a osteophytes, spurs of cartilage and bone at the joint. B. Synovitis. C. Bursitis. D. Tendinitis. B. Risk factors for OA include advanced age, female gender, muscle weakness, obesity, joint trauma, heredity, congenital or developmental anatomical defects, and repetitive stress. C. Clinical presentation. OA is characterized by a deep, localized ache in a joint. Pain and stiffness usually occurs with rest or immobility and lasts 30 minutes. Inflammation, if present, is mild. Patients will often complain of crepitus, a popping or cracking noise heard in the joint upon moving. OA most commonly affects the hips, knees, spine, feet, and hands. D. Diagnosis. 1. Physical examination. Joint tenderness, diminished range of motion, crepitus, and misshaped joints. 2. Laboratory tests. No specific lab tests are diagnostic for OA. However, if arthrocentesis is performed, synovial fluid will reveal mild leukocytosis with predominance of mononuclear lymphocytes. 3. Radiography. Narrowing of joint space owing to loss of cartilage, subchondral sclerosis, and osteophytes are seen. 4. The American College of Rheumatology (ACR) has defined criteria for OA of the hip, knee, and hand. OA of the hip is characterized by hip pain and at least 2 of the following: 1. Erythrocyte sedimentation rate, ASR 20 megameters per share. 2. Radiographic evidence of femoral or acetabular osteophytes. 3. Radiographic evidence of joint space narrowing. B. OA of the knee is characterized by knee pain, radiographic evidence of osteophytes, and at least 1 of the following: 1. Age 50 years. 2. Morning stiffness that lasts 30 minutes. 3. Articular crepitus on motion. C. OA of the hand is characterized by hand pain, aching, or stiffness, and at least 3 of the following: 1. Hard tissue enlargement of 2 distal interphalangeal (DIP) joints. 2. Hard tissue enlargement of 2 selected joints, 2nd and 3rd DIP and/or proximal interphalangeal, if from the first carpometacarpal joints of both hands. 3. Fewer than 3 swollen metacarpophalangeal (MCP) joints. 4. Deformity of at least 1 of 10 selected joints. Treatment. 1. Goals: control pain and other symptoms. B. Maintain or improve joint mobility. C. Correct or minimize functional limitations and disability. 2. Non-pharmacological treatments. The mainstay of OA therapy should focus on these non-drug therapies. A. Patient education may include tips on joint protection and exercise programs. B. Weight loss, if overweight can decrease pain and OA symptoms. Osteoarthritis and rheumatoid arthritis. 865. C. Aerobic exercise programs to increase muscle strength. D. Physical therapy for range of motion exercises and strengthening. E. Assistive devices, for example, canes, walkers, may help decrease joint load. F. Acupuncture leads to improvements in pain and function after 26 weeks, compared to placebo or arthritis education in patients with mild knee OA. G. Wedge insoles can help reduce mechanical stress in persons with medial knee OA. H. Thermal therapy, for example, hot shower or tub, ice pack, may be of benefit for some patients with OA. 3. Pharmacological treatment. A. Acetaminophen, a PAP, is considered first-line therapy by the ACR for OA. It has excellent analgesic and antipyretic activity, but no anti-inflammatory effects. 1. A dose of 4 grams day is recommended to avoid toxicity. Concomitant use of other medications with acetaminophen should be evaluated closely to avoid overdose. 2. Hepatotoxicity can occur in patients taking 4 grams of PAP a day. Symptoms can include nausea, vomiting, abdominal pain, malaise, and diaphoresis. 3. Because there is little, if any, inflammation in the OA joint, a PAP has been shown to be equally efficacious as ibuprofen and naproxen in patients with mild to moderate OA pain. 4. Studies have shown either a PAP immediate release or extended release is effective in treating mild to moderately severe OA pain. B. Nonsteroidal anti-inflammatory drugs. NSAIDs and cyclooxygenase 2, COX-2. Specific inhibitors are indicated in OA treatment when the response to a PAP is inadequate. Table 40-1. 1. Mechanism of action. NSAIDs are non-selective inhibitors of COX-1 and COX-2 as well as thromboxane synthetase. 2. Analgesia is seen with short treatment duration and at lower doses, for example, ibuprofen 200 milligrams a day. Anti-inflammatory response is seen with higher doses and usually requires several days of therapy to achieve anti-inflammatory effect. 4. Adverse effects. The FDA mandates that a published NSAID medication guide be issued with all NSAID prescriptions informing patients about the potential adverse effects. A. Gastrointestinal. Genotoxicity is caused by direct mucosal injury and inhibition of prostaglandins. Symptoms include dyspepsia, ulceration, and bleeding. I. COX-2 inhibitors may be an option for patients with a history of peptic ulcer disease. COX-2 inhibitors may be an option for patients with a history of peptic ulcer disease. However, the GI safety of these agents has not been demonstrated long-term. People at risk for GI toxicity include the elderly and those with a history of peptic ulcer disease, chronic alcohol use, high-dose or multiple NSAID use, and concomitant corticosteroid use. Table 40-1 selected anti-inflammatory drugs. Generic, brand initial daily dose, maximum daily dose. Non-cetylated salicylate salsylate. Disulcid 1,000 milligrams twice a day, 3,000 milligrams. Non-steroidal anti-inflammatory drugs, aspirin. Various 650 milligrams every 4 HRS 4,000 milligrams diclofenac. Voltaren 75 milligrams twice a day, 200 milligrams ibuprofen. Motrin. Advil 400 milligrams 3 times a day, 3,200 mg naproxen. Naproxen. Aleve 500 milligrams twice a day, 1,100 milligrams nabumetone. Rilifen 1,000 milligrams once a day, 2,000 mg Silindac. Clinaril 150 milligrams twice a day, 400 milligrams Tolmetin. Tolectin 400 milligrams 3 times a day, 1,800. Cyclooxygenase 2 inhibitor celecoxib. Celebrex 100 milligrams twice a day, 400 milligrams. 866, Chapter 42, the third. B. Renal toxicity results from the inhibition of prostaglandins. Although the risks are low, 5%, it does not appear to be dose-dependent and is usually reversible. Effects can include hyperkalemia, hyponatremia, increased serum creatinine, sodium and water retention, and acute renal failure. People with a risk for renal toxicity include the elderly and those with pre-existing renal disease. hypertension, diabetes mellitus, congestive heart failure, cirrhosis, and volume depletion, for example, hemorrhage, sepsis, diuretics, and diarrhea. C. Hematological effects are the result of decreased platelet aggregation. G. Hepatic toxicity, although not common, can include elevated liver enzymes. Patients at risk include those with a history of hepatitis, alcoholism, and heart failure. E. Central nervous system effects can include sedation, confusion, and mental status changes and are primarily seen in the elderly. Allergic reactions, such as asthma, urticaria, and photosensitivity, may be seen. Cross-sensitivity has been seen in patients allergic to aspirin. G. Cardiovascular CV effects, for example, myocardial infarction, stroke, hypertension, and heart failure, have been reported. Studies of celecoxib have shown a dose-related increase in CV events in patients with a history of colorectal neoplasia who were at risk of recurrent adenomatous polyps. The U.S. Food and Drug Administration, the FDA, recommends using celecoxib at the lowest possible dose for the least time possible. C. Other oral analgesics. 1. Tramadol, Ultram. Considered a good choice when the patient's pain is unrelieved by NSAIDs, when the patient cannot take NSAIDs, or when the patient experiences breakthrough pain while taking NSAIDs. A. Mechanism of action. Centrally acting analgesic that inhibits the reuptake of norepinephrine and serotonin and mildly binds to the receptor. B. Dose. 50 to 100 milligrams every 4 to 6 HRS, not to exceed 400 milligrams day, and 300 milligrams day in the elderly. In patients with impaired renal function, creatinine clearance, CrCl 30 ml Keenan, the dosage interval should be every 12 HRS, with a maximum dose of 200 milligrams. The extended-release formulation is dosed 100 milligrams daily with a maximum dose of 300 milligrams a day. C. Adverse effects. Although it is not an opioid analgesic, its side effects are similar: nausea, constipation, rash, dizziness, somnolence, and orthostatic hypotension. D. Drug interactions. Concomitant use with selective serotonin reuptake inhibitors, SSRIs, for example, citalopram, sertraline, fluoxetine, may cause serotonin syndrome. Tramadol is metabolized by CYP3A4. 2. Opiate analgesics, for example, codeine, oxycodone, are usually reserved for patients who fail single or multiple analgesic therapy. They may also be useful for acute exacerbations of pain. Side effects can include constipation, sedation, nausea, confusion, and respiratory depression. 3. Topical analgesics are effective in relieving OA pain in some patients. Topical therapy can be used as monotherapy or in conjunction with oral therapy. Capsaicin, for example. Zostrix is derived from hot chili peppers and with chronic use. 2 weeks works by depleting stores of substance P. Patients should be counseled to wash hands thoroughly after application to avoid contact with other skin, to avoid burning and stinging. B. Diclofenac, for example, Voltaren gel, is a topical NSAID approved for OA of the knee, 4 gm CHID, and hands 2 gm CHID. The max daily dose is 32 GMP a day. The same adverse effects as oral NSAIDs are possible, but studies show that they are rare. 4. Intra-articular injections. Corticosteroids may be useful in knee OA when inflammation is present. but are not routinely recommended in hip OA owing to administration difficulties. Duration of action is up to 4 weeks. Because of adverse effects on the bone, injections should be limited to 3 or 4 per year. Long-term benefits and safety have not been established definitively. Osteoarthritis and rheumatoid arthritis 867. Hyaluronic acid derivatives are intended to improve elasticity and viscosity of synovial fluid. They are indicated for the treatment of knee OA when treatment failure to other therapies occurs. Sodium hyaluronate Falgan 20 mg weekly for 5 weeks and hyaline polymers Synvisc 16 mg weekly for 3 weeks are 2 agents currently available. Most benefits are seen after the last dose. Effects are superior to placebo. These agents should be used with caution in patients with allergies to avian proteins, feathers, and egg products. Adjunctive treatments. These agents are widely used by patients. However, efficacy has not been consistently demonstrated in controlled trials. Glucosamine acts as a substrate for and promotes the synthesis of the glycosaminoglycans. The dose is 500 mg 3 times a day. Side effects may include GI discomfort, fatigue, and skin rash. Chondroitin helps protect against the breakdown of collagen and proteoglycans. It is usually found in combination with glucosamine, but the added benefits are not clear. Dose is 1,200 mg a day. Prolonged bleeding time and nausea. Surgical interventions, for example, arthroscopy, joint replacement, are considered when pain is severe and not responding to medical treatment or when disability interferes with daily activities. Fourth, rheumatoid arthritis. Etiology and pathogenesis. The cause of RA is not fully understood but appears to be multifactorial. It is considered an autoimmune disease in which the body loses its ability to distinguish between synovial and foreign tissue. Other factors involved in RA are as follows. 1. Environmental influences, such as infections or trauma, are thought to trigger the development of RA. 2. Genetic markers, such as human leukocyte antigen DAR4, HLA-DAR4, have been associated with triggering the inflammatory process in RA. Such markers, however, are not considered diagnostic because 30% of people with HLA-DAR4 never develop RA. 3. Antigen-dependent activation of T lymphocytes leads to proliferation of the synovial lining, activation of pro-inflammatory cells from the bone marrow, cytokine and protease secretion, and autoantibody production. 4. Anticitrullinated proteins and peptides are high specific for RA. 5. Tumor necrosis factor TNF, IL-1, IL-6, IL-8, and growth factors propagate the inflammatory process, and agents found to alter these cytokines show promise in reducing pain and deformity. 6. Inflamed synovium is a hallmark of the pathophysiology of RA. Synovium proliferates abnormally, growing into the joint space and into the bone, forming a pannus. The pannus migrates to the articular cartilage and into the subchondral bone, leading to destruction of cartilage, bone, tendons, and blood vessels. Clinical manifestations. 1. The onset of RA is insidious. In early disease, symptoms include malaise and anorexia, accompanied by symmetrically tender and swollen joints. Pain in the joints is common and aggravated by movement. Most commonly, the joints first affected by RA include the MCP and PIP joints of the hands, the metatarsophalangeal (MTP) joints, and the wrists. Other areas affected by RA include the spine, shoulder, ankle, and hip. C. Clinical course. The severity of the disease is variable. 1. Within 4 months of diagnosis, irreversible joint damage is detectable on radiographic images. The rate at which joint damage occurs is greatest during the first year. 2. Extra-articular manifestations can include rheumatoid nodules, anemia, peripheral neuropathy, kidney disease, CV effects, and pulmonary disease. 3. Causes of mortality in RA are cardiovascular disease, infection, respiratory disease, and malignancy. D. Laboratory assessment. 1. Rheumatoid factor RF is found in 60% of patients with RA. However, as many as 5% of healthy individuals will have elevated titers of RF. If initially negative, the test can be repeated in 6 to 12 months. RF is not an accurate measure of disease progression. 868, Chapter 42-4. D. 2. Erythrocyte sedimentation rate TSR and C-reactive protein CRP are markers of inflammation and are usually elevated in patients with RA. They can also help indicate the activity of the disease, but they do not indicate disease severity. 3. Anticyclic citrullonated peptide antibodies RCPA are found in most patients with RA and are useful in predicting erosive disease. E. Diagnosis and clinical evaluation. In 2010, the ACR and EULAR, European League Against Rheumatism, established a score-based algorithm criteria aimed at diagnoses before joint damage occurs. Providing the patient has at least one joint with active synovitis, swelling, then cannot be explained by another diagnosis. Definitive RA is defined as a score 6/10 based on 4 domains. 1. Joint involvement. For example, number and location of involved joints. 2. Serology, for example, RF, ACPA 3. Acute phase reactants, for example, CRP, ESR 4. Duration of symptoms F. Radiographic examination can reveal the extent of bone erosion and cartilage loss. An MRI can detect proliferative pannus. G. Treatment objectives. The goals in the management of RA are 1. To prevent or control joint damage. 2. To prevent loss of function. 3. To decrease pain. 4. To maintain the patient's quality of life. 5. To avoid or minimize adverse effects of treatment. H. Prognosis. Poor prognostic factors include active disease with multiple tender and swollen joints, evidence of erosion seen on radiographs, elevated RF and/or ACPA, and elevated ESR and/or CRP. Additionally, worse outcomes, including disability and morbidity, are associated with female gender, advancing age, cigarette smoking, and genotype. First therapy. The ACR published updated treatment recommendations in 2008 on non-biological and biological disease-modifying drugs. Non-pharmacological therapy. For example, exercise, joint protection, physical therapy, and were not included in the report as these do nothing to alter the course of the disease or prevent joint destruction. Consideration, however, may be made to include these as adjuvant therapy for mild to moderate pain relief. 1. Corticosteroids. Low-dose systemic corticosteroids, for example, prednisone, methylprednisolone, have excellent anti-inflammatory activity and are immunosuppressant. The lowest effective dose should be used because of adverse effects, for example, hyperglycemia, GI toxicity, osteoporosis. These agents have shown to slow joint damage. However, they are often used as bridge therapy as patients start on disease-modifying anti-rheumatic drugs, DMARDs, or during an acute RA flare. Non-biological disease-modifying anti-rheumatic drugs, NBDMARDs, Able 40-2, are used to reduce or prevent joint damage and preserve joint function, and should be considered within 3 months of diagnosis. Note: the 2008 recommendations only assess the use of methotrexate, MTX, leflunomide, sulfasalazine, hydroxychloroquine, and minocycline. Other NBDMARDs were not mentioned because of lack of clinical efficacy, side effects, or both. Methotrexate, MTX, Rheumatoid works by inhibiting dihydrofolate reductase and is considered standard therapy for RA. MTX is recommended for all patients with RA, as monotherapy or with other DMARDs, regardless of disease duration, disease burden, or prognostic factors. Concomitant use with folic acid may reduce side effects. B. Leflunomide, Arava, inhibits pyrimidine synthesis and is recommended for all patients with RA, as monotherapy or with other DMARDs, regardless of disease duration, disease burden, or prognostic factors. Because of its long elimination half-life, cholestyramine is recommended as a binding agent if serious toxicities occur or if the patient wishes to become pregnant. C. Sulfasalazine is cleaved by bacteria in the colon into sulfapyridine and 5-aminosalicylic acid. It is recommended for all disease durations and degrees of illness without poor prognosis. D. Hydroxychloroquine's mechanism of action for RA is unknown. It is recommended for those without poor prognosis and low disease activity of 2 years. 3. Biological DMARDs, BDMARDs, Table 40-2, can reduce or prevent joint damage, preserve joint integrity and function in patients with moderate to severe RA. They are used primarily in those failing an adequate trial of one or more NBDMARDs, or in patients with high disease. Osteoarthritis and rheumatoid arthritis 869. Table 40-2, disease-modifying anti-rheumatic drugs, DMARDs, time to effect, agent, brand, months, starting, dose, adverse effects, monitoring parameters, some drug interactions. Traditional DMARDs, methotrexate, 0.5, 6, 75, 15 mg/ml, weekly, nausea, diarrhea, LFTs, SRCR, CBC, chest, penicillin, cyclosporin, Rheumatrix, mouth ulcers, X-ray, NSAIDs, hepatotoxicity, hepatitis B and C, pulmonary toxicity, serology, myelosuppression, sulfasalazine, 1-3, 500 mg per BID, nausea, diarrhea, rash, CBC, LFTs, SRCR, iron, digoxin, warfarin, azulfidine gradually increase photosensitivity to 2-3 grams stain, 2 portavididoses, hydroxychloroquine, 2-6, 200-300 mg/BID, ocular, toxicity, rash, eye exam, SRCR, CBC, cimetidine, plaquenil, nausea, myopathy, LFTs, minocycline dinosine, NT, 100 mg per B, GI, rash, CBC, LFTs, calcium, magnesium, aluminum, iron, biologicals, lethal, onamide, arava, 1 bor, 100 mg day, po, diarrhea, nausea, the lefties, CBC, SRCR, PPD, MTX, rifampin, warfarin. 3 days, load. Then, infection, rash, HTN, hepatitis, B and C, 10-20, MGD day, alopecia, liver, toxicity, serology, etanercept, Enbrel, 0.253, 50 mg Snapchat, weekly. Abdominal, pain, Ha, PB, CBC, LFTs, SRCR, cyclophosphamide. Injection, site reactions, infections, infliximab, Remicade, 0.53 mg kg IV over 2 HRS at. Nausea. Ha, abdominal, PPD, CBC, LFTs, SRCR, none known, weeks 0, 2, and 6. Pain, dizziness, then every 8 weeks, hepatic, hematologic, infections, adalimumab. 0.53 mg kg IV over 2. Pain, dizziness, then every 8 weeks, hepatic, hematologic, infections, adalimumab, Humira. 0.251, 40 mg Snapchat every injection. Site reactions, PT, CBC, LFTs, SRCR, none known, 2 WKs, infection. Rash, Ha, continued, on next page, 870, chapter 42-4. First table, 42-2. Continued time, 2. Effect, agent, brand, or months. Starting, dose, adverse effects, monitoring parameters, some drug, interactions, anakinra, Kineret, 0.25, 100 mg day, SQ, Ha, injection. Site, CBC with neutrophil, etanercept, reactions, infection. Counts, LFTs, SRCR, thalidomide, abatacept, Orencia, NT, 10 mg kg IV at day 0. Injection. Site, reactions, PPD, CBC, LFTs, SRCR, anakinra, TNF, then 2 weeks. Infections, Ha, antagonists, 4 weeks, and nausea, HTN. Continuing, every nasopharyngitis, 4 weeks, rituximab, Rituxan, NTD, 1000 mg for at day 0. Injection. Site, reactions, hepatitis, B, serology, cisplatin, and 14. HTN. Infections, CBC, LFTs, SRCR, nausea, arthralgia, less frequently used, DMARDs, gold salts, oralate, 3 mg, 25, 50 mg instant message every, itching, rash, stomatitis, CBC with differential, penicillamine, 2-4 weeks, proteinuria, SRCR, urinalysis, conjunctivitis, D-penicillamine, 3-penicillin, 125, 250 mg po daily, nausea, rash, CBC, SRCR, gold, iron, zinc. Cupramine, increase gradually. 2. Photosensitivity, antacids, digoxin, 250 milligrams TID, myelosuppression, antimalarials, azathioprine, imirin, 2-3, 50-450 mgDA, chills, fever, NTV, CBC, LFTs, allopurinol, diarrhea, leukopenia. Cyclosporine, neuro, 2-4-4, 3, thin, mgkg, HTN, ha, nausea, BP, SRCR, LTFs, serum, CYP 450. 3AB4, paresthesia, drug levels, inhibitors, MTX, leukopenia, digoxin, allopurinol, glucocorticoids, BP, blood pressure, CBC, complete, blood count, ha, headache. HTN, hypertension. Instant message, intramuscularly. Ivor, intravenously. LFTs, liver. Function tests, MTX. Methotrexate, NHD, no data available. NCV, nausea and vomiting. NSAIDs, nonsteroidal anti-NFL-amatory. Drugs, PO by mouth PKD. Tuberculosis, skin test, Snapchat, subcutaneously. SRCR, serum, creatinine, TNF, tumor necrosis factor. Including 2008 recommendations by the ACR, Osteoarthritis and Rheumatoid Arthritis 871. Activity and poor prognosis. Note, the only BD-MARDs included in the 2008 guidelines are abatacept, adalimumab, etanercept, infliximab, and rituximab. The remaining BD-MARDs were not included either because they were not FDA approved at the time of the publication or because of very infrequent use, high incidence of side effects, or both. TNF blockers, for example, etanercept, Onbrel, infliximab, Remicade, adalimumab, Humira, golimumab, Simponi, and certolizumab pegol, Cimzia, inhibit the inflammatory response mediated in immune cells. Etanercept, adalimumab, and certolizumab can be used as monotherapy or in conjunction with NTX. Infliximab and golimumab is only FDA approved for use with NTX in RA. These drugs are recommended if high disease activity is present early in the course of the illness. 3 months with poor prognosis. These drugs are usually considered when patients do not achieve an acceptable response to MTX or other NBD-MARDs. B. Abatacept. Orencia is the first T-cell co-stimulation blocker. It is used as monotherapy or NBD-MARDs. Abatacept is recommended with MTX. NBD-MARD does not work in the presence of moderate disease with poor prognosis. C. Rituximab Rituxan is an anti-CD20 monoclonal antibody. Depletion of the CD20 B cells appears to affect the autoimmune response and helps with the chronic synovitis associated with R. It is used when the patient fails MTX and/or multiple DMARDs and has high disease burden and poor prognosis. Severe, even fatal, infusion reactions have been reported. D. Anakinra Kineret is an IL-1 receptor antagonist. It is used as monotherapy or in conjunction with any DMARD except a TNF blocker. E. Tocilizumab Actemra is an IL-6 receptor monoclonal antibody. It is indicated for moderate to severe RA in adults who have not achieved response with one or more TNF antagonists. It can be used as monotherapy or with NTX or other NBD MARDs. 4. Combination therapy. Concurrent use of several NBD MARDs has been studied. The 2008 guidelines support the following combinations: MTX-HCQ, MTX-sulfasalazine, MTX-leflunomide, and sulfasalazine-HCQ-MTX. Some patients currently receiving DMARD therapy with new or worsening symptoms have benefited from combination therapy. Combination therapy with multiple biological DMARDs were not recommended in the 2008 guidelines because of increased side effects and/or lack of efficacy. 5. Treatment recommendations are published by the ACR and are available at rheumatology.org. Surgical treatment, for example, carpal tunnel release, total joint arthroplasty, joint fusion, may be considered when pain is severe, range of motion is lost, or joint function is poor. Study questions. 1. Which of the following statements best characterizes osteoarthritis? OA. A. OA is a common disorder characterized by diffuse inflammation leading to increased disability. B. OA is a systemic disorder characterized by degenerative changes in the joint and typically exhibits extra-articular involvement. C. OA is a common disorder that affects the normal synthesis and degradation of cartilage. D. OA is a common disorder that adversely affects bone density and leads to falls and fractures. E. OA is a systemic disorder frequently associated with localized inflammation and pannus formation. Which of the following agents is recommended as first-line drug therapy by the American College of Rheumatology for patients with mild to moderate osteoarthritis? A. Ibuprofen, Motrin. B. Celecoxib, Celebrex. C. Diclofenac gel, Voltaren gel. D. Tramadol. 872 Chapter 42. 3. When consideration is given to diagnosing osteoarthritis, which of the following statements is false? A. Joint tenderness, diminished range of motion, and/or articular crepitus can be assessed. B. Radiographical evidence will show joint space narrowing. C. Common patient complaints include a deep, localized ache in a joint. D. Laboratory evidence reveals a high sedimentation rate, positive rheumatoid factor, and anticyclic citrullonated peptide antibody. E. Morning stiffness lasts 30 minutes. 4. Which of the following disease-modifying anti-rheumatic drugs are recommended by the American College of Rheumatology for all patients with rheumatoid arthritis, regardless of disease duration and degrees of disease activity? E. Methotrexate and sulfasalazine. B. Methotrexate and hydroxychloroquine. C. Methotrexate and etanercept. Methotrexate and leflunomide. Methotrexate and minocycline. 5. In order to reduce toxicity with methotrexate, concomitant administration with what vitamin is recommended? Folic acid. B. Thiamine. Ascorbic acid. D. Pyridoxine. Riboflavin. 6. All of the following statements are true about the use of hyaluronic acid derivatives in osteoarthritis. OA, except A. Should be considered in those not responding to simple analgesics. B. Should be considered for the treatment of knee OA. C. Should be considered as disease-modifying agents. D. Should be considered if no allergies exist to feathers or egg products. E. Should be considered to improve elasticity of synovial fluid. 7. Which of the following agents used for osteoarthritis or rheumatoid arthritis require dosage adjustment in patients with renal impairment? A. Prednisone, B. Acetaminophen, C. Oxycodone, D. Glucosamine, E. Tramadol.